Good afternoon, everyone. My name is Sharinda Williams. I'm the communications lead at the Morehouse School of Medicine, National Center for Primary Care. We want to welcome you to seize this revenue opportunity. Connect to chronic care management. The Chronic Care Management Payment Program makes it financially feasible for clinicians to deliver care between office visits. When clinicians meet specific criteria, they can be reimbursed for care coordination activities, such as phone calls outside of regular office visits to manage Medicare patients with multiple chronic conditions. So without further ado, I would like to turn over the presentation to Phoebe.
Thank you so much, Sharinda, and welcome everyone. We're so very glad that you joined us for this topic because it's going to be presented by subject matter experts. And so we're looking forward to hearing every single tip that they will share with us. As you know, Hybrid Solutions is Georgia's Health IT Center, and we're located here at the beautiful Morehouse School of Medicine campus. We are within the National Center for Primary Care, and so our mission is to really help promote the interoperability of information between practices and anything that will optimize your success in providing care for your patients, increasing your revenue, and so on. So I am Phoebe Nelms. I'm the program manager here for Outreach and Technical Assistance. So it's my pleasure to select topics that will be of interest and also support particularly clinicians who are eligible to report for the Quality Payment Program, MIPS track. We really are focused on Georgia clinicians in helping them be successful in participating in this program. So our guests today, Jim Bowling, Tanya Mallory, and Bert Lively, are also very committed to providing support for practices and healthcare organizations. They deliver patient engagement solutions that help practices improve patient outcomes, and one of their focuses is the Chronic Care Management Program and how that can be used to reduce readmission rates. So they're part of the Pre-Medics team. They're founders, co-founders, and they strive every day to enhance patient communication and build dynamic tools to improve care coordination. So I would love to turn it over at this time to Mr. Jim Bowling, and he will give us a little bit of background on his fabulous team.
Great. Thank you so much, Phoebe, and good afternoon, everyone. Thank you for attending today's session, and thank you to the HighBridge team for inviting us to participate in this exciting topic. Again, I'm Jim Bowling. I'm a co-founder of Pre-Medics. We're based in the Sandy Springs area of Atlanta. As Phoebe mentioned, our company provides software, services, and a turnkey approach to helping providers manage non-face-to-face patient engagements in this new world of value-based healthcare. Our goal for today is to give you a blueprint for CCM success. We're going to be walking you through a history of CCM. It started back in 2015. We're going to take you through what has occurred since then, talk about some of the new reimbursement codes and how CCM has evolved. Hopefully we can answer some questions that you are probably asking and researching if you haven't already started CCM with regard to whether it makes sense financially, operationally, how it may be able to help support your other objectives like MIPS and MACRA, what works, what doesn't work. We are going to be touching on some of those types of topics today. And talking about what makes for a successful program. So on one hand, we want to be talking about what's going to drive overall quality for your practice and your patients. On the other hand, we also want to be talking about what's going to maximize your reimbursement. And so in this new world of AWV or CCM, we're going to be looking at AWV, your annual wellness visit, as a central component of chronic care management. and helping to lay the foundation and the roadmap for success throughout the year. So in this new perspective on chronic care management, we want to talk about a more holistic approach to chronic care management. We're going to be talking about a number of supporting CPT codes that can be added to enhance the engagement and also maximize revenue for your practice. And we're also going to be talking about what's coming in 2020. You've probably seen some new regs, opportunities and around remote monitoring and other codes that are making this very exciting and opening new opportunities. So as we talk about chronic care management today, these are some of the topics we'll be covering. We're going to be focusing on what you can be doing on the 365 days or 360 days of the year when a patient's not in your office. You're typically seeing them about 5 days out of the year. With that, I'm going to go ahead and introduce our other team members here. Tanya Mallory is joining. Tanya will walk us through a history, and then I'll be asking some questions throughout the presentation to facilitate some topics that may be of interest. So with that, I'll turn it over to Tanya.
Hey guys, it's great to be here with you all. Hopefully this will be very helpful for you, and I can answer all the questions that you may have and haven't thought about yet. So I just want to start with explaining why CCM and what's all the buzz about CCM when it comes to the Medicare, Medicaid services and the things that their objectives for the entire program. So I am going to explain a little bit. I'm not going to go into great detail about these items, but you will understand after I show you some of the background information on why this is a high priority and a topic that CMS keeps expanding. So everyone is very familiar with the disease trends. I'm not going to spend too much time on them, but you can see there is 9 million people not taking aspirin as recommended, 40 million people with uncontrolled blood pressure, 39 million not using statins when indicated, 54 million adult smokers, and 71 million adults who are physically inactive. This means a catastrophe for the Medicare system if these people age into that population where Medicare insurance kicks in. And so it is a huge initiative to get on the front end and be more preventive. If you overlay the disease trends with the healthcare expenditure trends, and you look at the prevalence of chronic disease and obesity, you can see what's causing this trend line. And finally, in our system of healthcare, we're actually trying to get on the front end of these trends and try to change the trajectory of those cost curves. So if you look at the in the background, in 2015, Medicare introduced CCM into primary care. You know, I think for everyone, it seems to be something that's now very commonly spoken about. But in 2015, and we're talking 4 years ago, it was almost unheard of. And at that time, in those first 2 years that the program was conducted, there was only on average 47 patients a month participating in these services. And so now there is quite a bit more, but there's still not enough in the mind of CMS. And the purpose of having these, and I'm going to show you more of the data, is so that if you take a look at the services that CCM will impact, and this is the net for, and everyone's very familiar with Medicare wanting to reduce, wanting to reverse those cost curves. This is CMS's data. It was analyzed and published last year by Mathematica. And if you take a look at the data, you will actually see for those patients with CCM services, the hospital services, cost of hospital services and admissions was decreased. The cost of skilled nursing facilities decreased. Outpatient services decreased. Physician services increased. So these are the payments to the primary care providers for providing the CCM services. But the net was a huge savings for CMS. And this trend continues, and it gets larger the more patients are participating in these programs. So this is the main reason that CMS and Medicare is continuing to push and expand the CCM services. So if we use AWVs as the baseline for CCM and service expansion, I'm going to allow Bert to explain the potential impact for your practices and your patients. But before I turn it over to Bert, I want you guys to think about your individual practices. Consider your patient population over the age of 40. Not 65, 40. Think about that patient population. It's not uncommon, and I do sanity checks all the time, and go into Walmart, take a look around, and see if these numbers will actually work in your mind. But what we're seeing is about 40 to 50% of the entire patient population has a BMI above 30. 50% of them will have high cholesterol, on or off statins. It doesn't matter. Some of them are very non-compliant. 50% are hypertensive. 50 to 70% are pre-diabetic. And I believe that there's at least 50% of the population that's pre-diabetic. The remaining population, there's about half of those that aren't even diagnosed as pre-diabetic. 20 to 25% have mental health concerns. 20 to 25% have lung issues. And there's at least 10% that are impacted by the social determinants of health. So that's why using CCM and some of these other services that Bert's going to mention, it's going to be so useful for you and your practices to expand these services. And Medicare has actually paved the way for us to do that. So Bert, I'll turn it over to you.
I'm Bert Lively, and as Tanya mentioned, I like to talk about the AWV being the cornerstone of your practice. You know, the typical doctor has, maybe 2,000 up to 3,000 people in their EMR system, and that's, obviously not just your Medicare population. Half of that is Medicare, and then you have all the third parties. But the bottom line is most practices are going to have about 400 to 500 Medicare patients who are eligible for AWVs just sitting in their practice. And the thing is if you do the AWV correctly, then you can actually have those 400 or 500 patients guide the rest of your practice. And I'm going to explain that, based on, some of that information that Tanya just mentioned. It's a huge opportunity because these people who are eligible for the Medicare annual wellness visit are also the most likely patients that you can have to get engaged in a true wellness program that includes chronic care management and other variables we're going to talk about here in a second. But the bottom line is these people are ready to engage in their health care, and when they do that, wellness improves. We like to say at Pre-Medics, we put the patient at the center of our universe, because if we put the patient at the center of the universe and we treat that patient to the utmost, we believe that everything else will fall in line. As Jim mentioned earlier, the typical doc sees a patient between 4 or 5 days out of the calendar year. Now, the thing is, that means that there's 4 to 5 days during the calendar year that you can have an impact face-to-face with that patient on their health and well-being. So what happens in the other 360 days or so? The patient's on their own. So what we're going to try to do is engage that patient in their health care over those 360 days, and it all starts with the annual wellness visit. Now, the reason I say that you got to do it right is when we go in and we look at some of the practices we work with on the annual wellness visit, a lot of times they don't even have it billed appropriately. We went into a practice, for instance, that had around, I believe it was 250 to 300 patients who were eligible for the annual wellness visit. Doc said, well, I do annual wellness visits on everybody, regardless of whether they're Medicare patients or not. So we went in and looked, and he'd only billed about 80 of those annual wellness visits correctly. So you got to make sure you do it right. But when you do the annual wellness visit, you do a very comprehensive questionnaire, and you include other variables. You can uncover a lot of situations that may or may not already be in your EMR system. As you can see here, what we're trying to do is we're expanding the care team and expanding the care cycle. You start out with an AWV, and then you move into typically into escalations. The visit, the patient comes back in for a visit, and that's typically the way that you do things. But now, if you move over to an expanded care cycle, we can actually together with your practice work as an extension of your practice to not only help do the AWV and the CCM, but move into various health coachings and various follow-ups, do the escalation ourselves, and actually deliver that information back into your EMR system, and actually work as an extension of your practice to make it look like if there's 2 or 3 practitioners in your practice, and there's a lot of things that you would like to do. You'd like to do behavior counseling. You'd like to do obesity counseling. You'd like to do a lot of smoking cessation, but you don't have the time nor the manpower to do it. So utilize our expanded team to actually provide those services outside your practice. And these are a lot of information, a lot of things that you can do and that we can bill for on a consistent basis, to make sure that we're treating the patient to the extent that they need to be treated. I like to talk about smoking cessation as one of my favorites, because docs always tell me, well, Bert, why would I want pre-medics to actually work with us with a smoking cessation program? I do smoking cessation in my practice. I said, that's great, Doc. I said, how many times, you said earlier that you see the patient about 4 to 5 times a year. How many times do you actually get to do smoking cessation with that patient? Oh, well, I do it once or twice. And I said, well, I'm not trying to be a jerk, but how's that working out for you? Because I need to know what you're saying. If you can get somebody to stop smoking after only 1 visit, then I need to know what you're saying, because I'm fixing to write a book and create a program and be a multimillionaire. And I get a lot of chuckles at that. And I said, of course, because you really can't do that and impact the patient's health and well-being and get them to stop smoking by talking to them once a year. So why wouldn't you actually partner with pre-medics? Let us actually provide a continuous smoking cessation with a patient to actually try to get that patient to actually back off on their smoking some. Jim, did you have a question?
And yeah, I'm just gonna interject there. So this is something we do specialize in, but we do realize you have your own resources. You probably been looking into this and may be doing a lot of this already. I think what Bert and what we're alluding to is we're happy to work with you to help you evaluate areas where you can optimize your reimbursement. And sometimes they're just, you may, resource restrictions may be one of those areas that's causing you to have difficulty in maximizing the reimbursement. So regardless of whether you're doing it and you hire the folks to do it, or if you partner with an outside third party like a pre-medics or someone else, we would love to talk to you and see what sorts of challenges or obstacles may be getting in the way of you maximizing that reimbursement.
Right. Thanks, Jim. And this is sort of the expansion on the chronic care management that I'm talking about. This last slide is something that I like to bring to people's attention to, because remote patient monitoring is sort of new to the healthcare system. When you say remote patient monitoring, most folks think, oh, well, that's what happens when a patient goes to a cardiologist and you hook on a Holter monitor. And I say, well, in the past, that's been, basically what it is. But now, in today's day and age, there's all sorts of new opportunities to provide remote patient monitoring. And as like I said, put the patient at the center of our universe to make sure that they're getting the highest quality of care that we can possibly give them. I like to talk about this blood pressure cuff and this glucometer first, because the biggest thing is when you have a patient, when you identify a patient who has high blood pressure or who is type 2 diabetic, then you want to monitor them. And especially with the type 2 diabetics, you can actually give them this glucometer. It's a wireless glucometer. And the glucometer can actually sync in to your EMR system. We can, with the help of a health coach, actually get this patient to be able to prick their finger a few times a day, hook this in, and then you can actually see where a patient's blood sugar was between visits. And these are also opportunities for billing. The last thing I want to talk about right here is this necklace. For your patients who have congestive heart failure or on dialysis, you know that the biggest obstacle that you have is when these patients gain body weight. A lot of times they end up back in the ER and sometimes in the ICU because it becomes a very dire situation. Now you can have a patient actually wear this necklace for 5 minutes a day, and it will actually ping your office when the patient begins to take on fluid, and you can get that patient in for a visit and hopefully ward off that serious situation that may occur and actually get them before they actually gain weight. And so these are just a couple of things that we have available, and we can actually show you how you can integrate this into your complete, comprehensive, expanded care model. Tanya, did you want to pick up here?
Yeah. So, guys, I think we've talked a lot about that service expansion, and the reason why you're very familiar with the pressures that are happening. You've got your MIPS quality measures, whether they're the HITEC, MIPS, MACRA, ACO, whatever those quality measures are. Then you've got bottom line to comply with those, or there's a huge revenue deficit that will need to be filled. If you can imagine, when we talked about, think about all of your patients above the age of 40. Everyone knows all of the MIPS are being graded on not your Medicare population, but your entire population. And that's what the CMS is focusing on, is changing the behavior and making the practices reach out, kind of innovate, look at things a different way so that they can prevent that patient population from aging into Medicare with a huge disease burden. So no matter what the scores are, you could have perfect scores. Everyone's familiar with the Michigan ACO scores. Their quality scores were nearly 100% across the board, but there was no cost savings. And what we're talking about, if you look at that, if they treated it as and study those ACO data, a lot of that was based on check boxes. They were hitting all of the quality measures, but they weren't preventing hospitalizations. And therefore, without the cost reduction or disease reversal, then it's very likely that we'll go nowhere, and certainly there will not be any financial benefit. So along comes CCM. Think about that. in the theme. Along comes CCM. CCM is reach out any way you want to reach out to that patient at least once a month. Once you're reaching out to the patient, then you're actually anticipating issues, addressing issues on the spot. You're not waiting for those 3 or 4 office visits on a yearly basis. I don't know if you guys are familiar with this, but 30% of all heart attacks occur in patients between the age of 35 to 54. Again, CCM is paid for other than Medicare population. It is paid by many commercial payers. So if you look at all of the chronic disease that is the most prevalent, whether it be heart disease, blood pressure, obesity, diabetes, hypertension, all of these disease states are reversible. And medical care affects only 10% of the outcomes. So we've got to change lifestyle, we've got to change behavior in order to affect the ultimate end game of cost and disease reversal, meeting that triple, quadruple aim that CMS is passionate about. So they have developed programs that are supporting that mission. CCM is one of them. There is also transition care management and then the AWV that's already been mentioned. If you look at the revenue opportunities, whether you're rural health or traditional primary care, then there is anywhere from $400 to $800 a year annual for revenue, potential revenue from CCM, and transition care is about $230, and annual wellness is another $200, $250, depending on where you are. And so if you layer on the additional opportunities that Bert just mentioned, the comprehensive assessments, now these have to take place outside of an EM visit, and these can be done remotely in many cases, and especially with remote monitoring and some of the rural health telehealth codes that are available, then there's lots of these services that can be delivered through telehealth. But if you will actually extend the practice to providing these services, now keep in mind the idea is to meet that patient on their own terms, outside of the practice, while they're driving to work, while they're at work, while they're leaving church, while they are sitting at home, while they are cooking dinner, whatever's going on, we're going to meet them with increasing touch points. You guys all remember the patient-centered medical home years ago, and that was very successful data in showing that higher touch points equals lower cost in patients. This is the same concept, but with very distinct CPT codes. And so once you take a look at these CPT codes and what the revenue opportunities are, there's $300 a year from the assessments, another $115 a month from remote monitoring, from the health coaching and providing the services that are needed to change behavior. That's another $300 a month, and many of these services are preventive services, which means they are zero out-of-pocket expense for the patients, no copays or deductibles. And then, of course, pharmacy reconciliation is another. So if you think about the potential revenue by the additional services, expanding your care team beyond the 4 walls of the practice, having additional staff, whether that be pharmacists, health, registered dietitians, PT, exercise physiologists, all of these types of services will be able to support your end game being the quality metrics that you are trying to meet, your increased revenue. And this is true population health delivered on a hyper-personalized way. So if you think about the triple aim, the quadruple aim, these these initiatives will meet those. They're very consistent. They improve outcomes. They reduce costs for the system, the entire healthcare delivery system, as well as the payer, while increasing revenue for you. Patients are more satisfied, and of course, less out-of-pocket expense for the patients. It's already been mentioned. So let's move on to talk about what's coming in 2020. There is so many new codes that are coming up, and this shows you that this is not a program that CMS is walking away from. They have introduced new codes for opioid use disorders, and they have increased the payment for TCM. They have increased or further refined the CCM service codes. Now, we don't know the exact amount yet. They're still to be determined, but they will pay. There's new G codes that are going to separate out for additional CCM services. So you have right now the 99490 is for 20 minutes, and I don't know that I've ever experienced a 20-minute intervention with a patient on a monthly basis. So most of them run 40, 45 minutes and well past an hour. So those that effort will now be extended with the new G codes, and there will be higher payments for them. There will also be a change and adjustment to the comprehensive care plan requirements that are now being required during those CCM in order to build the CCM codes. And they're introducing with CCM, you have to have 2 or more chronic conditions. And with this new code that's PCM that's coming up, it will be 1 primary single serious high-risk condition that will be new and reimbursed for in 2020. We do, I think, the group here at Highbridge has information on those new codes if you are interested in receiving that information later.
And Tanya, could you talk a little bit about other payers who are reimbursing for CCM and some of these codes?
Yeah, I mentioned earlier that we talked about that about 30% of all heart attacks are happening in patients 35 to 55 years old. So many of the commercial payers have gotten on board with also paying for the CCM services. I've experienced all of the major payers paying for CCM in many of the states. Now, of course, every payer and every program benefit is a little bit different, but by and far the majority of them are paying. Many of the state plans are paying for these and other services.
I know we've stressed a lot in this presentation the importance of a more holistic approach to CCM. One of the things that we've seen is back when the initial codes launched, there was a rush in the industry moving towards 99490, that 20-minute engagement. What we found and many providers found is that there just wasn't enough reimbursement in that one code to really make it a profitable venture once you're paying all your support staff and keeping that sustaining your organization with that one code. I think what we're talking about today is layering on all of these additional codes and using CCM as the gateway to those additional codes. While you're doing CCM, you can be looking for other opportunities and actually closing gaps and providing preventive screenings and other other codes like smoking cessation counseling and obesity counseling every month. So there's, that's where I think the new paradigm is emerging in CCM. Also, remote monitoring is just an exciting opportunity where we can, practices can now layer that on, and ultimately it creates a better healthcare experience for patients while it's helping to boost your bottom line.
Yeah, and I think I'd like to, kind of emphasize that, the remote monitoring, especially in a patient-centered approach, the remote monitoring is invaluable. I can't tell you the number of times we've had patients that weren't checking their glucose or weren't checking their blood pressure. And think about it, they're coming to the practice 3 to 4 times a year. Every 3 to 4 months, you're giving them a hemoglobin A1C. It's 8, 9, 10, 12%. They're taking their medicine. They're coming back every 3 to 4 months, and you're being dinged from your quality measures because you've told them to improve their diet. You've given them the medicine. You've made sure they're taking their medications, but they're not changing. Understanding what their choices are improves their diabetes, their disease conditions so significantly. We've had so many patients. One 78-year-old woman, as 6 months ago, was on high blood pressure medicine. She was type 2 diabetic, and within 6 months, by measuring her blood pressure and her diabetes and watching what different choices do to her off her blood pressure medicine and is now reduced all of her type 2 diabetes medication in half and has lost about 40 pounds. And so she's using these measurements because she doesn't want to continue to, she wants, her ultimate goal is to take a trip to see her children in another state. So she is very adamant in understanding what choices to make, and this is self-reinforcement. And they don't need to speak with a health coach to see, I ate potato salad and now my blood glucose is through the roof. Don't eat potato salad. So it's very obvious and it's very effective. And there is so many of these services where if they have, in Medicare alone, there is sometimes copays and deductibles, but when you have the Medicare, Medicaid population, then the secondary, and whether or not it's Medicaid or any other secondary, almost always the secondary picks up all of the copay or deductible amount. And so there is very little out-of-pocket expense when you're using these services with patients.
So you're saying, just to emphasize that, I know there were some questions around copays and deductibles. Maybe you could talk a little bit more about that, just clarification on that, because you're saying that Medicare, that there is very little out-of-pocket expense, but could you talk a little more about that, just deductibles and copays? I know that's a really hot topic in CCM, and as well as when we're talking about some of these other codes and what the patient could incur.
Yeah, so for chronic care management for the non-rural health or FQHC population, that is usually $8 per month. For the FQHC and rural health, that's about $15 out-of-pocket expense for the patients. But if they have a secondaries always pick that up. And so that means zero out-of-pocket expense for the patients. And so if patients are have an issue with those services, there are other preventive services, obesity counseling, cardiovascular disease counseling. All of these are preventive services that have zero out-of-pocket expense based on ACA law as preventive services. And so as long as the right modifier goes in with them, then and marked as preventive services, then there is no patient responsibility for some of those. So if you've got those patients that are cost sensitive and can't afford that, then you can offer additional services that are preventive that will keep their out-of-pocket expense at a minimum, if not zero. Now, also, so that you know, for DME, I know that their question may come up when we're talking about remote monitoring about the cost for the patient and these devices. There is, again, depends on the patient's plan, but for diabetes, there is lots of rules where the insurance companies will pay for glucose monitors on a monthly basis, whether that's the glucose sticks or the monitor. Now, that means that the practices have to call them in as prescriptions, and that's why you see so often in the patient's pharmacy list in the EMRs, they will have a glucometer in there. But if the practices call it in as a prescription to the pharmacy, pharmacists can run it through insurance. Insurance can pick up the cost on those things.
And Tanya, we've talked a lot about the impact on CCM and these related CPT codes on MIPS and MACRA objectives, and just in the last couple of days, we've talked about how many practices may be checking the boxes on MIPS and MACRA. It appears that they are doing the right things to avoid penalties or to get further reimbursement on their MIPS and MACRA metrics. But if they're not moving the needle or just checking the boxes on a standard CCM program without really using all of these new codes holistically in the patient's care, they may not see the impact and therefore may not see those incentive payments for MIPS and MACRA.
Yeah, so I think everyone realizes that quality is presented as a big piece of MIPS and MACRA and certainly the ACO quality measures, and it should be, but it's not the total number. Cost has a huge impact. So if you are not preventing hospitalizations and not preventing events, heart attacks, stents, strokes, then that is a huge problem, and it will be a struggle to get the bonus payments in any format, whether it's the MIPS or quality through the ACOs that are needed to grow not only these services but your practices themselves. So you've embraced the quality side of it, but now we've got to really, as an entire industry, embrace not only the quality side, but truly moving the needle on disease. And I believe strongly and passionately that you can't do that without changing the patient's behavior and having them engage in the entire healthcare program, whether their own health, participate, understand, and making different choices on a day-to-day basis.
Great, thank you. So I'm looking through, I'm seeing there are some questions that I believe Bert has been answering some of these questions about, and I think we've also answered questions around reimbursement or with regard to deductibles and copay, and there's some questions around ACOs, and Premedics does work with ACOs. These are the same tools that are used to help to reduce the cost of care while improving patient quality metrics and overall care. So the formula works. I think the exciting thing is that there's an emphasis on increasing provider physician revenue while we're working proactively to keep these patients out of the acute care setting. Tanya, did you have anything else, or maybe we could give some time here to have some questions?
I think we should open it up to questions.
Well, thank you. This is Phoebe with Hybrid Solutions. I cannot tell you how great it was to have you go, not only from the high-level perspective of CMS's mission to really drive innovation and control costs, address the quadruple aim, but also down to the actionable items for practices and practice managers and clinicians, talking about the codes and how to really have a holistic approach within the practice, layering those codes to close gaps in care and really impact patient behavior. You took us to church, Tanya. I really, really enjoyed all that information that you shared with us. So we want to open up. Does anyone have any questions from our audience or attendees that have not been addressed? We'd love to hear from you, and that's why we allow time for this session. We have that came up. Can a specialist bill CCM or only primary care practitioners?
That is changing, and it depends on the specialist. If there are guidance documents that Highbridge does have available for anyone that's interested. There are some specialists that can, it's designed for primary care, but there are specialists that can bill for CCM if they are responsible to manage that patient's care. In that, endocrinologists, nephrologists, cardiologists who tend to manage multiple chronic conditions and the overall care, then yes, they can bill CCM, and that's often done. For some of the more highly specialized areas, then I think that would have to be addressed on a case-by-case basis.
Awesome. We also have another question. How do you see allied health professionals, PTs, OTs, SLPs, and RDs, aligning services within the practice providing CCM? Namely, how would an RD bill for CCM?
So those are excellent questions. So registered dietitians are invaluable and actually are the only provider that can provide diabetes education and diabetes self-management. So you have to have a dietitian, a registered dietitian, to actually be able to provide those services within the practice or program. And so other allied health professionals, depending on their area of expertise, then they can participate in both CCM from either way. It's a chart review from a support to a provider. It just depends on the population and exactly that individual and level of experience. But they can, all of them have a place within the program and can address different needs from the patient's perspective.
Wonderful. It takes a team. You mentioned several chronic conditions that many people experience. I was really taken aback by the statistic. 30% of heart attacks occur between people the ages 35 through 54. Is there a list of qualifying conditions for CCM, or does any chronic illness count?
So there's several documents out there that list example chronic conditions, but if there is two or more, they give you a few suggestions, but anything that I actually have not seen any chronic disease, not acute, but chronic disease that has not qualified as a chronic condition under the CCM coding. There may be some that I'm not aware of, but I have not run across them. But there's obviously the top contenders. The obvious ones are anything related to diabetes, depression, heart disease, hypertension, COPD, asthma, mental health, obesity. All of these are chronic conditions that will contribute and certainly make up about 80% of your patient population.
All righty, that's good to know. So is there like a time frame in which they should submit the CCM claim?
So there actually no concrete answer on that, and I recommend that you speak with the state or your carrier on these, especially for the commercial payers. But typically, once the 20 minutes is completed, whatever that is, then it's billed for. Or if it's some point in time after, you use the timely filing requirements for any of the claims that you're submitting, then that same principle would apply here. So you can actually submit claims. It doesn't have to be on the day, but you cannot submit a claim until the 20 minutes minimum requirement is met.
Got you. How about providers who, I know many of the a few of the quality payment program participants render services in skilled nursing facilities or assisted living facilities. Can they bill for CCM services furnished to those beneficiaries?
No, normally those are not allowed, but that would have to be, typically CCM is in a non-facility type structure, and it should be outside of the primary care. So you would have to either consider other codes or speak with the carrier if there's something else that you're particularly doing that you need to find the best code to fit for.
Okay, gotcha. Well, we really have enjoyed your panel sharing your expertise on this subject. And I know you mentioned, just one last thing, you mentioned that the reimbursement opportunities, you broke it down, $300 to $400 for certain activities. Now, is that per year? Is that per patient? What's the time frame on the potential positive reimbursement impacts for a practice who is really holistic in their approach to layering these CCM and the annual wellness visit and all the other
Yeah, so that's a great question. So our experience is there's about 30% of the patient's adult population that's going to be ready for change. And if that means 30% of your patient population. And of that 30%, if you add up all of that potential revenue, that's about $2,500 to $3,000 new revenue per patient per year. So if you do a comprehensive patient-centered approach, you will have, whatever your 30% of your patient population is multiplied by about $2,500 a year in new revenue. Now that will be a changing number, and that 30% is ready for change today, and then there's another 30% that's going to do it at some near future effective date. As soon as the kids go to school, as soon as I'm done with the wedding, whatever that is. And then you'll have 30% that will do it at a much longer time, and then 10% that will never be ready for change. So you will have, anywhere from 30 to 60% of your patient population in and out of these services as they move through that change. And it does take about 6 months to establish a new habit and affect change.
Oh, excellent answer. Yeah, I really like that focus on the way to impact healthcare is really to keep our patients motivated and help them understand the impact of their choices, because ultimately that's who has the power to effect that change, is the patient. So we really want to thank you again for the excellent information you presented to us, helping to understand the potential impact on the healthcare system and the individual patient and the practice, the providers, bottom line. Just very, very helpful and practical information. So we thank you all for joining us and for this lovely animation.
Thanks so much, guys. It's been great.
Awesome. So thank you. We have
Thank you.
we have a list of resources here and links to additional information regarding this topic. The presentation will be available as a YouTube link after it is edited. It's about a week or two. We hope that you will access that on the Hybrid Solutions website. We have a webinar coming up on the third Tuesday of every month. Next one will be targeting the Medicaid EHR Incentive Program participants, getting them ready for their reporting for 2018. If you have additional questions, here are the contact emails for each of us on this presentation today, and we look forward to you reaching out to us. Our mission is to support the innovation of healthcare so that the four main objectives can be, we can move the needle on that: cost, access, quality, and the health of our clinicians. So thanks everyone for joining us, and we hope that you have a wonderful day.